Afternoon and good morning. I'd like to thank you all for joining us today and to welcome you to this webinar on Cataract, Global Data for 2030, jointly hosted by the World Health Organization and the International Centre for Eye Health at the London School of Hygiene and Tropical Medicine. During the next hour, we will share summaries of 3 new publications related to cataract surgery that have been published today. First, an update on the global and regional data on effective cataract surgical coverage with projections to 2030, published in the Lancet Global Health. Second, published in Lancet Healthy Longevity, a deeper analysis of cataract in Kenya, presenting a dynamic model that estimates the number of people that will die before receiving cataract surgery. And third, a summary of the new WHO recommendations on quality of care in cataract surgery management, published by WHO today. In the second half, we will have a panel discussion about these topics with an opportunity for you to post your questions or comments in the Q&A section on the Zoom meeting controls. My name is Matthew Burton, and I'm joined by 2 colleagues from the International Centre for Eye Health, Andrew Bastawrous and Jackie Ramke. Stuart Keel, the technical lead for eye care at the World Health Organization, Monica Bitok, who is the head of the eye health program at the Ministry of Health in Kenya, and Katie Overby, who is the CEO of the Keel Blindness Project. Stuart, over to you.
Thank you very much, Matthew. It's a great pleasure to be with you on behalf of the WHO Eye Care team. Welcome everybody to the webinar. Thanks to the International Centre for Eye Health for their great collaboration in the organisation of this webinar, but also leading the generation of the new data that will be highlighted soon. We feel that this is a very important day to really raise the profile of cataract. We know, of course, it is the leading cause of blindness, very important public health problem, and therefore a high priority at WHO. Very pleased to see the new data, which we'll see very soon from Matthew, is important because it tracks progress at around the midpoint of the 2030 WHO and World Health Assembly target, and really sheds light on some of the challenges moving forward. Also looking forward to introducing the new WHO document that is a practical tool providing minimum standards around quality of care in cataract. And yeah, without further ado, Matthew, back over to you, and looking forward to the webinar.
Great, thank you, Stuart. So first, an overview of the 2025 update on effective cataract surgical coverage. As Stuart mentioned, cataract remains the leading cause of blindness globally. For the year 2020, it was estimated that 17 million people were blind from cataract. That's about 39% of all blindness worldwide. Cataract is also the second leading cause of moderate and severe vision impairment globally, affecting around a further 83 million people. Recognizing this enormous public health challenge and unmet need of cataract surgery, in May 2021, the World Health Assembly endorsed 2 key indicators for eye care: effective refractive error coverage and effective cataract surgical coverage, ECSC, and set a target for ECSC of a 30 percentage point increase by the year 2030 from the baseline in around 2020, while paying careful attention to equitable service delivery. In 2020, WHO convened a working group to develop definitions and methodologies for both new indicators. You can read about these in this report published in 2021. ECSC is an effective coverage indicator, which is WHO's preferred approach. It is a population-level indicator that is derived from surveys, and in summary, it's defined as the people in a population with a good visual acuity outcome following cataract surgery as a proportion of those who currently have unoperated cataract, plus those who have previously had cataract surgery. In 2021, WHO also updated the definition for a good surgical outcome from 618 to 612. As mentioned, ECSC is a population-based estimate from survey data. The primary source of data for ECSC is currently the rapid assessment of avoidable blindness survey methodology. RAB7 is the latest generation of RAB. Delivered digitally, it enables faster, more accurate collection and analysis of secure, high-quality eye health data relevant to current eye health priorities. It includes an optional module for the collection of additional data around diabetic retinopathy. RAB7 has been developed through a collaboration between the International Centre for Eye Health and Peak Vision in consultation with a steering group made up of representatives from key stakeholders in the global eye health sector. A population-based sample of people is assessed for current cataract or prior surgery. There are three metrics that we typically then calculate in relation to cataract surgery. Firstly, cataract surgical coverage, or CSC, effective cataract surgical coverage, ECSC, and the relative quality gap, RQG. Taking this hypothetical example of 1,000 people, 80 have untreated cataract, that's the red faces, and 40 had cataract surgery previously, that's the blue faces. First, to estimate the cataract surgical coverage, CSC, you divide the number of people who have previously had cataract surgery, irrespective of their outcome, by the number of people operated, plus those with unoperated cataract. So in this example, the CSC is 33%. To estimate the effective cataract surgical coverage, you need to take into consideration the outcome of the surgery. Some operated people will have non-good outcomes. That's defined as visual acuity less than 6/12. You divide the number of people who have previously had cataract surgery with those who've had a good outcome, that's 6/12 or better, by the number operated plus those with unoperated cataract. In this example, the ECSC is 23%, down from 33% CSC. The third metric is the relative quality gap. This is the difference between CSC and ECSC as a proportion of CSC. So in this example, the relative quality gap is 30%. The baseline ECSC report, which included data on 55 countries, was published in 2022 and fed into the World Health Organization baseline reports on the indicators. This updated report published today builds on an expanded list of primary data sources. It includes 233 surveys conducted in 68 countries to provide empirical estimates for ECSC at the 6/18 threshold in terms of outcome of vision. Estimates of the the relative quality gap and an analysis of the causes of that gap. And then finally, modeled temporal trends from the year 2000 to 2030. I'd like to draw your attention to the appendix, which is available online, which has a lot of additional detailed material on the methods that surveys use to calculate the data and the results. This figure plots the cataract surgical coverage as blue markers on the right, and the effective cataract surgical coverage, the red markers on the left, for each of the 68 countries. The line between reflects the quality gap between CSC and ECSC. There is a very wide range of values for all three metrics, with ECSC ranging from between 22 and 78%. The regional median ECSC values at the 6/18 outcome level range between 15% for the Africa region and 45% for the Eastern Mediterranean region. For more recent surveys, we have access to visual acuity data at the 6/12 threshold, that new updated WHO good outcome level. And as expected, this reduces the ECSC values a little bit across the board. We use data from 120 RAB surveys that analyze vision to the 6/12 threshold to calculate the overall global and regional median percentage contributions of causes of non-good outcomes, that is, people who have visual acuity of worse than 6/12 who have previously been operated. Globally, refractive error and ocular comorbidities both accounted for 26% each, intraocular complications for a further 20%, and posterior capsular calcification at the global level, 11%. The median percentage point increase in effective cataract surgical coverage at the 6-12 level that might be achieved by addressing the residual refractive error following cataract surgery was around 4%. 17 locations had effective cataract surgical coverage data at the 618 threshold from surveys available at time points several years apart. These are shown in this graph. For 9 of these countries, the 95% confidence intervals do not overlap, suggesting a significant increase in effective cataract surgical coverage. The largest percentage point increase is ECSC at 618 for Qatar at 27% between 2009 and 2023. With the exception of Mali and Senegal, there was limited evidence of increasing ECSC at 618 from the African region. As mentioned, we used 228 datasets to model regional and global estimates for ECSC at the 618 level from the period of starting at 2000 up to projecting forward to 2030. These figures show the trend for the individual WHO regions. In the current decade, from 2020 to 2030, the modelled increase in ECSC at the 618 threshold was 4% for the Africa region, 8% for the Americas, 6% for Eastern Mediterranean, almost 14% for Southeast Asia, and 18% for Western Pacific. Currently, there is insufficient data from the European region to be able to model this trend. For the year 2025, the model predicted a global ECSC at the 618 threshold of 48.2%. Between 2000 and 2020, there was an estimated 15.6% increase in ECSC at 618. In the current decade, from 2020 to 2030, we estimate that there's only an 8.4 percentage point increase globally. This is set against the overall target of a 30 percentage point increase for this decade. So in conclusion, globally and regionally, ECSC is increasing much more slowly than the World Health Assembly target of 20 percentage points increases this decade. Action is needed to increase cataract surgery urgently. The relative quality gap remains large in all regions, but addressing post-operative refractive error is both a realistic opportunity to boost effective cataract surgical coverage. And it's really important to report the reasons for a non-good outcome to inform programs in terms of how to improve quality of outcomes. I'd like to thank you very much for your attention and joining us today. I'd like to highlight the contributions of 4 members of the ICEH team: Ian McCormack, Emma Archer, David McLeod, and Jackie Ramke, who did a lot of the work in doing this analysis. I'd like to also thank the wider authorship group and the ECSC study group, particularly country representatives who've contributed a lot of data to this analysis. And finally, our funders, the Indigo Trust, the Wellcome Trust, and the Fred Hollows Foundation that have supported this work. Thank you very much.
Thank you, Matthew. We'll share my screen. Welcome, everybody. Great to have you here with us. Good morning, good afternoon, or good evening, depending where you are in the world. So I'm going to present some work that builds on the ECSC modelling, but tries to position it in a way that might help drive in-country action. And so here we're going to talk about the prevalence of death in people with vision impairment from cataracts before treatment, with a case study from Kenya. This was published today in the Lancet Health Longevity. The work that I'm sharing is the work that was partaken by the co-authors who are here on the page. And we probably don't need to tell anyone who's on this call that cataract is a very well-known, long-standing condition that has been reported for over 4,000 years in different forms of literature, for which we've made humongous progress in terms of treatment innovation. Yet the reality is we're not progressing as fast as we need to. This, for me, is something that became very visceral whilst living in Kenya 15 years ago and seeing blind patients coming to the outreach clinics that I was part of, and seeing that many people attending these clinics had often been blind for a decade, such as these two ladies who were in one of the outreach clinics who were both blind from cataract. The lady on the left had been blind for more than 10 years, and the person sat next to her was her best friend. But until a few moments after this photo was taken, they didn't know they were sat next to each other. So blindness had not only removed their sight, it had removed their community, and it had removed the connection to the things that they love. So as we look at this data, it's really important for us to always come back to framing who are the people that we are trying to solve this for. And so when we look at the data that we've just heard, what we've tried to do as a group is build a dynamic model that takes this snapshot data, which has, here's effective cataract surgical coverage, and if we simplify it now to just the surgery has had a good outcome. So you end up with what we call the cataract can. So in this model, the only way from the backlog through to the operated is by having cataract surgery. And this can be measured through an indicator called the cataract surgical rate. So that's the number of cataract operations per million of population per year. And so that tells us the rate at which people are moving from the backlog into the treated group. The other important measure is how many people are being added to that backlog over time, because the backlog isn't static. So people are added to the backlog. And that happens as people go from normal vision to mild impairment and so on as they develop more severe forms of cataract. So if the incidence of the new cases are greater than the number of operations happening in any given year, the backlog will grow. Conversely, if it's the other way around, if the cataract surgical rate is greater than the incidence, we can expect to start eroding away at the backlog. And so statistically speaking, the only other way out of the backlog other than surgery is to die prior to receiving treatment. So from an epidemiological perspective, you either leave the backlog having had surgery or having died prior to receiving the opportunity for surgery. So to try and kind of conceive of this as a dynamic model, I like to think of it as a bathtub. So if you imagine the incidence, so the new cases is the rate at which water is coming from the tap in to fill the bathtub. The backlog, which is the amount of water in the bathtub at any one point in time. And the cataract surgical rate is the rate at which it drains out of the bathtub. So if the water coming in and the water draining is at the same rate, then the bathtub level remains the same. If the drainage is greater than the inflow of water, then we would expect the level to drop. And conversely, if the inflow is greater than the outflow, we'll expect it to start overflowing. And that overflowing is the equivalent of people leaving the backlog having died, not having been treated. So we've tried to build a dynamic model to show what is going on based on data from Kenya. So we've been lucky to work with Ministry of Health in Kenya and multiple colleagues to model this scenario. And before I share the data from this model, we do want to position that Kenya, when we look at the ECSC data, this is from the paper that Matthew shared, Kenya is relative to other countries in the region, actually one of the highest performing countries in terms of its ECSC and CSC metrics. So just to hold that in mind as we go through this, this model. So to build this model, we need data from a few different sources. So one was from a large set of RAB7 surveys conducted across 14 counties in Kenya across 2022 to 23. Which was supported by CBM in the Vision Impact Project. And the data from that showed us that for Kenya as a whole, on the backlog as of 2025, we estimate there to be 360,000 people who are needing a cataract operation today. We also have estimates in terms of the cataract surgical rate. So the surgical rate, so per million, is about 700 per million, which works out to be about 40,000 operations per year. To calculate the incidence, the ideal mechanism is to have a cohort study. So to be able to track people over time and see how many people develop vision loss from cataract over a period of time. And we do have that data from the Nakuru eye disease cohort study. So my colleague here from many years ago at ICEH, when Jukumatenge conducted a large population survey in 2007 and 8. And then I followed up those 5,000 people 6 years later to see how many of those people over time had developed vision impairment and developed cataract as a cause. And that required going to 100 different locations, doing very detailed assessments of everyone's vision status and ocular health. So we used the data from that 6-year study to determine the incidence of cataracts, the number of new cases joining the backlog. And in summary, we found that to be 120,000 new people per year developing vision impairment from cataract. So straight away, as you look at this model, the inflow is 3 times greater than the outflow. And also bearing in mind, incidence is person level joining, but cataract surgical rate, 40,000 surgeries doesn't necessarily mean 40,000 people being operated on. It works out to be an operation per 1.3 people. So in other words, for about every 4 surgeries, that happens on 3 people. So that leaves us with the question of, given that inflow and outflow, how many people are dying before they access treatment? And so the summary of the model, which is detailed in the paper, including all of the assumptions around the model, show that between the year 2025 and 2030, of that original 360,000 people on the backlog, we expect 236,000 of them to have died by 2030. And then if we push that out to 2040, by which time everybody on the backlog has either been treated or died, it's 280,000 of that original 360. You can also see the backlog has grown from 360 to 635. And so in conclusion, that means 77% of all of the people who were on the backlog today are projected to die before they get the opportunity to access treatment. So 3 in every 4 people. So we can leave you with that sobering message that although we're making progress, the cost is very human, and we're not progressing fast enough. And although for these 2 ladies, the result was a positive one, they both were able to access surgery, and it restored their sight and their connection to one another. What we do know is, sadly, although these are the stories we like to tell, the reality is that isn't the story for most people. For every 4 people today who need a cataract operation, as things stand, only 1 will access it. Thank you very much for listening.
Thank you, Matthew and Andrew, for the great presentation. So briefly now, I will introduce WHO's document that has been launched today, titled The Summary of Recommendations for Quality of Care in Cataract Surgery Management. So this is intended to be a very practical document for governments, planners, NGOs, other stakeholders who are involved in implementing cataract surgery on the ground. I wanted to frame this going back to the global target. Matthew spoke earlier about this global target and how we're tracking towards achieving this target. And what I wanted to highlight is, of course, that as countries set out to strengthen cataract surgery, as we go towards achieving this target, both components of access and quality are extremely important. And this was particularly highlighted, the importance of quality, in the Lancet Global Health publication, which found that on average, the relative quality gap, and which was the difference between coverage and effective coverage, was 36.7%. So that basically means that approximately 1/3 of people who underwent cataract surgery do not currently have a good quality visual outcome. But as we saw from Matthew's results earlier, that if we add up the number of people, the proportion of these cases that were due to needing eyeglasses post-surgery, plus intraoperative complications, plus the need for laser surgery for posterior capsular pacification, the majority of these cases could be implemented in terms of addressing the quality issue. In fact, it's around 60% of these cases could be addressed with these interventions. So what this does highlight is that where the delivery of quality cataract surgery remains a challenge, there really is a very good opportunity to improve effective cataract surgery coverage, often through measures that do not involve, I should say, significant additional investments. So although the measure of effective cataract surgery coverage captures an important element of quality, which is the effectiveness up the top of the diagram up here, there are other important components of quality that must be considered in the planning for cataract surgery management. And they include things like safety, people-centeredness, timeliness, equity, integration, and efficiency. And with this in mind, and in order to support countries and other stakeholders with guidance in this area, WHO, through consultation with a large group of international experts, developed this summary of minimum quality standards of care in cataract surgery management. So what is it? It is an evidence-based and expert-agreed recommendations for improving quality of cataract surgery that's applicable to most settings, and in particular, low and intermediate resource settings. It covers the three main phases of cataract surgery, including the preoperative care, intraoperative care, and postoperative care. What does it include? It includes recommendations for the quality of care across 7 key components of preoperative care. I won't go through all of them, but these include things like recommendations around preoperative assessment, waiting time for surgery, recommendations about the use of optical biometry, IOL availability, and also selection. It also includes 7 key components, recommendations around 7 key components of intraoperative care, including things like the surgical technique, infection control, intraoperative complications. And lastly, it includes 4 recommendations around 4 key components of postoperative care. And it includes things like intervals recommended intervals around follow-up visits, recommendations around what designates a good outcome, what proportion of the population we should be aiming for that should achieve a good outcome, and also recommendations around post-operative complications. Who is the target audience for this document? The primary audience is policymakers and planners that are responsible for developing protocols and policies around cataract surgery, but also managers of eye care programs within countries. There's several other potential end users, including eye care service providers, to put into action the recommendations at a facility level, health professionals to verify or align the care provided with these standardized evidence-based clinical care recommendations that have been extracted from high-quality existing guidelines, and also donors and development agencies when supporting cataract service provision within low and intermediate resource settings. So as I said, that's just a very brief overview. I encourage you all to go to the WHO webpage. We can put a link to the document in the chat here so you have access to the document. Before I close, I wanted to acknowledge the huge number of experts that are listed on the screen here from all regions that were involved in supporting WHO with the development of this guidance. A couple of special mentions to the Dana Centre for Preventative Ophthalmology that were responsible for doing the formative work of the review of all of the existing guidelines and synthesizing all that to support WHO in the next phases of development. Also, the working group within IAPB responsible for cataract, who we liaise with throughout the development, that was in fact led by KT, who will be joining the panel discussion soon. And last but not least, really a big acknowledgement to the Fred Hollows Foundation for the generous financial support provided towards the development of this document. And with that, I will pass back over to you, Matthew. Thank you.
Great. Thank you very much, Stuart. That was really exciting to see, and I'm sure everyone's looking forward to going through that document in detail. Great. I think everyone's with us. So now we're going to, over the second half of the meeting, we're going to have a bit of a panel discussion. We've got a series of questions that are going to dig into some of the key issues that have been highlighted in these three presentations. During that time, please do make use of the Q&A function in Zoom to pose your questions. If we don't have time to get to some of those questions, and we'll try and do that, but if we don't, what we're planning to do is take all the questions from this afternoon's webinar and this morning's webinar and do a frequently asked questions kind of document that will be shared with you, or all people who register for the meeting, along with links to the papers and links to the webinar recording as well. So we will endeavour to answer the questions either today or in the next day or so. So without further ado, I'd like to ask Monica to open our discussion for us. And the question I'd like to ask you about, Monica, is given the persistent backlog in cataract in many countries, with the perspective of your leadership role within the Ministry of Health in Kenya, which of the health system innovations do you think are currently proving to be most effective at scaling up cataract surgical services?
Yeah, thank you. Thank you very much, Matthew, for that question. And I'd just like to also thank the presenters who talked before me. And I think that's a very important question. And when we're looking at this, it's important to approach it from the demand side and the supply side, while also ensuring that we are giving comprehensive services, or we are using a comprehensive approach, not just looking at surgery in isolation, but the entire process, and ensuring that services are patient or people-centered. And first, I want to tackle it from the community side. So what strategies do we have to ensure that we are creating demand and that services are accessible? So number one of the biggest barriers from the community level is cost. Cost is a key barrier that hinders people from accessing cataract surgical services. So strategies that ensure that the cost barrier is addressed, such as health insurance, social health insurance, to reduce out-of-pocket expenditure is really, really important. And while this also addresses the cost barrier, it also ensures that services are somehow sustainable. We also need to look at physical access, because in our settings, we'll find that physical access, especially in areas that are vast geographically, with poorly developed infrastructure, patients have difficulties accessing cataract surgical services. So models to address patients or people who live in such areas are really important so that they can access services. And this can include things like having mobile clinics, because in some of these vast areas, it may not be possible to establish stationary eye clinics that patients can access easily. So having models that probably use mobile eye clinics or planned outreaches and linking them to referrals, I think is really, really important. And also at the community level, we need to look at the myths and misconceptions or misinformation that goes on out there, because this is a key barrier, because patients then fear to come for services. So how do we ensure that we address this? And we can use strategies such as using champions, people who've had successful surgeries, helping us to advocate at the community level, or even opinion leaders at the community level who can help us translate our technical jargon into a language that communities can understand. Because sometimes when you talk, it's quite technical and it's may not be understood. So it's really important that we use people that can pass the message across, and also targeting the decision makers. It could be a spouse, it could be a child who's financially supporting the parents, because sometimes you don't reach these people, and they're the ones who determine whether the people we are interested in are able to access services or not. Yeah, so from the health system side, I'd like to look at this from the primary healthcare level and then the secondary level where we have our eye units. So primary healthcare is really important, and integrating primary eye care into primary healthcare is really, really key, because primary level facilities is where our patients first get into contact with the health system. So when we embed primary eye care into our primary healthcare facilities, then we're able to reach these patients and ensure that they are referred early and without delay. And program data from different projects that have been implemented in Kenya have shown that 70 to 80% of eye conditions identified in communities do not require specialist services. They can be managed at the primary level. So managing these at the primary level means that we reduce unnecessary referral and unnecessary costs incurred by the patients, and also decongest our hospitals so that our staff can focus on the complex cases like cataract surgeries. So I think primary eye care, we're ensuring that this integration at the primary healthcare level is really, really key. And it also ensures, it serves as a triage point and a referral for patients who have cataracts to the higher level facilities. At the secondary level, it's important that we have efficient services and that our patients are getting a positive experience, because when they get a negative experience, then that drives the demand down. But when they have a positive experience, when they go back to their communities, then they speak positively and advocate for patients to come forward for surgery. So I know we've discussed about quality, but I think this is really, really key. And it's not just, we shouldn't just focus on the surgery itself, but the entire process, from when the patient interacts with the system, or even from when we are reaching them at the community level. I think we need to look at the entire process, not just the surgery in itself. And it's important that we audit ourselves. We audit the outcomes, but we also audit the other aspects of the health system. Yeah, so and just to conclude is that when we have satisfied clients, then they become our advocates. And our positive outcomes directly drive community demand. Yeah, thank you.
Thanks, Monica. They're fantastic points there. Lots of really rich, important points there. Just if I could ask a follow-on question, thinking about, particularly around the Kenyan context, what specific policy levers you have found to be helpful in shifting things?
Yeah, so some of the levers that I would like to speak about, number one, is the community level health promotion and early identification. And in Kenya, there's a lot of focus on primary healthcare. And we have what we call the primary care networks and the community health promoters, and we can use this basically to help us carry out health promotion at the community level. So that's one key lever, given that you already have that system in place, so we can just use that and integrate eye care into that. And we even have an eye care module in our community health promoters training manual. Then the other thing is integration of primary eye care into primary healthcare. I think this is really, really important. I've spoken about it. I don't think I need to explain further. Then health system strengthening. And this means that we need to ensure that our workforce have an enabling environment, number one, in terms of consumables, equipment, infrastructure, and also having a well-skilled workforce that is optimally used, because sometimes because of challenges of consumables and all that, then we find that we are not using our workforce optimally. And also where we need to upskill our workforce, then also that needs to be available so that we are giving quality services. Then we also need to look at sustainable financing mechanisms. And we have policies that reduce financial barriers for patients, such as social health insurance. And in Kenya, we have what we call social health insurance, basically. And what this does is that compensation of health facilities for things like cataract surgeries, for example, and especially for the public hospitals, was increased from compared to the previous insurance that we had. And this enables the facilities to be able to generate income. And we also have policies that allow ring fencing of funds within the hospitals, the funds generated within the hospital. So I think this is really important in ensuring that we have sustainable services, because we can generate our own income within the eye units and within the hospitals where those eye units are located. Then I think something that we really need to think about is about reaching the communities that have poor reach, our nomadic communities, the communities in the arid and the semi-arid areas, and the underserved populations. I think that is an area that you've not comprehensively covered. And I think it would be good to have a model that works for them, because we cannot have a one-size-fits-all, but we need to have it contextualized depending on the community. Thank you.
Monica, thank you so much. That was fantastic. I'd like to turn to Katie now, if you want to unmute yourself, Katie. And I'd just be really interested to hear from you what you have found through the work of Keel Blindness and the other things you've been involved with over the years. What are the primary causes of difference in quality between countries that you have observed?
Well, thank you, Matthew, and thank you to all the presenters. Really, really important research and guidelines coming out today. So really appreciate being a part of this. I think when we look at quality, there are a number of different factors, obviously, but the main factors that I've seen throughout work in a number of different places really revolve around training as well as equipment. Certainly, these are exacerbated by prior to now the lack of a consistent minimum standard. But I do think that the key is really ensuring that all surgeons at whatever level really have the opportunity to train and then practice, so that as they are delivering care, we all know that each cataract case is going to be different. It's going to have different complications and different unique circumstances. But we want to make sure that people really have sufficient training to be able to address what that care is needing, as well as liaise with others to ensure that both the pre-op care and the post-op care is what it needs to be. I think one of the other important pieces is, as I mentioned, making sure that there is the right kind of equipment involved in the process. You mentioned that ocular comorbidities was one of the leading causes of poor outcomes. And, in many ways, some of this comes down to, do we have equipment to do biometry so that people can identify some of these pieces in advance? Do we know what some of these other comorbidities are, to make sure that the proper training is at the bedside, and that we're prepared for knowing when to do the right surgery, how to do it, and what other additional post-op care might be needed around there. So for me, I guess the final thing I would say is that a factor more broadly in looking at our quality is our ability to have comprehensive data collection. So obviously, a lot of the data that we already saw earlier in the presentation is critical to be able to be measuring any progress or even the current status. And we know that in many, many places, we don't have that kind of comprehensive data.
Great, thank you very much, Casey. Kind of building on some of those points that you've raised, are there any particular actions beyond the things that you touched on already that you have found, or programs have been involved with, found have really promoted that increased quality? Perhaps drawing on some of the stuff that's coming out of the WHO manual as well.
Sure. Well, I would start where I just finished off, which is, I think what you get is what you measure, or what you measure is what you get. And so being able to accurately assess where we're seeing success, where we have opportunities for improvement is really critical to starting that improvement. I also think that now, having clear minimum standards is going to be extremely helpful in a number of different areas, to be able to start looking at it and saying, are we putting some of the minimum best practices in place? And I want to be clear, I do think that it's important for us to recognize, quality of life was mentioned earlier. And so taking somebody from seeing light only to being able to count fingers is a significant improvement in life, even if it's not a 6/12. Obviously, I think we all want to continue to strive for that target. There's no doubt about that. But I do think we need to think about that in terms of the impact on the individual. But again, I think training, not just ensuring that someone has the basic training, but also building a system so that every surgeon, particularly those who maybe have less experience, having a system where they are, where they have the support of more experienced doctors, to make sure that we're building that sort of that cycle of quality that we want is really important. I mentioned the equipment. I think the other piece that I would really emphasize is one of the other leading causes of poor outcomes was refractive error. And I think we see all too often that refractive error care and cataract services are pursued separately. And I think we all need to really be thinking about this from a patient-centered point of view, and really bringing those together, and making sure that we are partnering as NGOs to provide comprehensive care, which is in the end going to provide the best quality outcomes for each and every patient.
Super, thank you very much, Casey. I'd like to turn to Jackie now. Jackie, how do you think we can use these and similar data to better understand inequality in terms of cataract surgical provision?
Thanks, Matthew, and congratulations to everyone on the presentations. So first, I guess I wanted to highlight a point that we make in the paper, which is that the lack of gender disparity at the global level that we've reported doesn't mean that we no longer have a gender inequity problem. So while it's really promising to see the smaller gender disparity than we're used to seeing in a lot of eye health outcomes, I just wanted to highlight that the data that we've presented are aggregated and modeled. So that means that there's still many parts of the world where gender disparity remains a significant problem. So I sort of encourage us all to think and draw on local data when we're planning gender responsive programs. And then I guess along similar lines, I think is sort of encouraging us all to expand the social axes along which we explore disparities, and that these will be different in different settings. And Monica gave some really nice examples from Kenya of groups that we should be thinking about in terms of service access and quality. And I think the eye care indicator menu and other WHO tools give us some really useful service indicators that we can monitor to see whether or not we're moving in the right direction in terms of driving up ECSC. And I think Katie sort of pointed to that as well, the importance of expanding what we're thinking about. And I just thought I'd highlight the example of preoperative visual acuity, which can be a really nice proxy measure for thinking about access to services. And so here in Aotearoa, New Zealand, where I live, we know that our Māori, who are our Indigenous peoples, present for cataract surgery with much worse preoperative visual acuity than other New Zealanders. So we don't have survey data here in Aotearoa. So sort of monitoring preoperative visual acuity and knowing about this inequity means that we could prioritise efforts to improve access to services for Māori, and knowing that any improvement that we can make for access for Māori would mean that we are contributing to increasing our ECSC. And I guess the last point I wanted to mention, sort of the added benefit if we're going to expand the social axes that along which we're sort of monitoring service access and quality of services, is to understand, to think about intersectionality and sort of recognizing the potential for barriers to improve, to increase the more social axes along which a person experiences disadvantage. So, you know, an example is that not all women have the same lived experience. And so women with access to more resources are able to access services. And so if we're thinking about perhaps rurality and gender, or perhaps social support and marital status or socioeconomic status at the same time as gender, we'd get a much more nuanced picture of people's experience. And so maybe that's something to think about as well, and being able to target specific groups when we're planning services to drive up ECSC.
Great, thank you very much. Really important insights on that intersection of different axes and the need to really target groups that are being left behind, and the importance of disaggregating and really understanding what's happening in the population.
Absolutely.
Yeah. Stuart, may I turn to you now? And I just want to dig into some of the caveats that there might be around using CSR, cataract surgical rate, and ECSC, both for tracking progress and reporting.
Yeah, thank you. It's a very important question, Matthew. And I think it's, I think this leads on quite well from a few of the comments KT made and also Jackie made before, is of course effective cataract surgery coverage, cataract surgery rate are very useful indicators at a country level to periodically track outcomes and impact of the work done at the country level. They're sort of the one point in time snapshot of access, and in the case of effective cataract surgery coverage, also quality of services. But as alluded to, a much more comprehensive set of indicators are needed to inform routine planning for cataract surgery services. And WHO really has recognised this need, and in 2021 and then subsequent in 2022 and 3 published an indicator menu, and then more of the first aggregate module with a more comprehensive set of indicators that can be integrated within routine health information system reporting. And these included indicators such as waiting time for cataract surgery, as Jackie mentioned before, preoperative visual acuity, and also surgical outcomes. At the moment, we're looking to further operationalize that, and we have now a case-based indicator menu set that even includes additional indicators, dropout rates relating to cataract surgery, and those types of additional complication rates, those types of additional indicators. So really, we will be looking at the moment and working with a couple of countries to start to implement this module and move it forward. We recognise that strengthening the health information system around eye care, but in particular, there's a big opportunity around cataract care. It should be a priority for us moving forward. And for this to be successful, though, we must say that it's not an easy thing to do. It does require time, resources. It requires the different ministries coming together, different components of the ministries coming together, from the eye component to the health information system. Also the NGOs helping with convening and technical work around implementation as well. So it is a lot of work. It's not a quick fix, but I think certainly it is worth the endeavour.
Thank you. It's really exciting to see real momentum building now in this space. And I think what's coming through is the importance of data, not for data's sake, but to really shape and drive action, to track progress, but ultimately it's about moving it forward so that people really benefit. Thank you, Stuart. Can I turn to Andrew now? And I want us to kind of slightly change our focus now onto incentives. What you think needs to change around the incentive structure to really solve the problem of cataract and surgery, moving it from a situation we are today to something that's really sustainably moving forward for us as a global community.
Thanks, Matthew, and thanks to everyone who's online with us. So I'll answer it in two parts. One is kind of building on some of the comments already made around the importance of being able to do routine quality measurement. One thing that is covered in the paper, that quality has many dimensions that go beyond visual acuity. So one thing is being able to have a straightforward, reliable way to measure not just visual outcome after surgery, but also visual function, quality of life, satisfaction with the service, things that actually drive measures of, are people likely to uptake the service again for the second eye or recommend a colleague. And so that's, if you like, being able to measure the patient incentive to go again or recommend to another. From the supply side, from the hospital, I think often the elephant in the room that isn't discussed is we're chronically under-resourced in eye care. But one of the reasons is the incentive base as a surgeon or surgical team doesn't align with the impact that needs to be made. And that's because, broadly speaking, surgeons have to choose between either doing well or doing good, which means they can make a good income working in the cities, which is why you see the distribution of surgeons is primarily in the big cities, the metropolitan areas, where they can derive an income from those who can afford out-of-pocket payment. And those who are working in the more rural, serving the more vulnerable groups, are more attached to where there's external financial support. And I think unless we change the script on that, we're never going to accelerate the progress to the level we need to. So the question is, what can we do to unlock the financial shift that happens when someone's sight is restored in the individual or the household, in a way that means the provider of services is no longer choosing between an income, a reliable income, and serving those who are of a low income. And we're seeing potential models around that where there is an opportunity to shift that, particularly when there's a very strong functioning social health insurance mechanism that covers cataract. So for the high volume units who can treat patients at a level where they are generating a surplus for treating the lowest income people because of the reimbursements, that starts to create a really positive environment in terms of starting to reinvest resources in doing outreach. So I think there's a real role for philanthropic support to be catalytic rather than funding time-bound programs or projects. But it will require us to blend different financial models, really understanding the incentive is, it's not that surgeons don't want to support people, actually many people are driven to, but they equally have to make a choice, and they have their own families to support and so on. So I think that's a problem we have to grapple with.
Great. Thank you very much, Andrew. I think the challenge of creating an incentive structure is a win-win for everyone, so crucial. And I think it's something we haven't really attended to nearly enough. So thank you for raising that. Jackie, can I come back to you again and talk a little bit about, ask you a bit about data? I know you're doing quite a lot of thinking about using service data from cataract surgical services at the moment. And I just wondered what your observations might be around what are the biggest challenges, but also what are the opportunities for collecting high quality cataract service data, potentially at a national scale, kind of building on some of the things that Stuart mentioned as he spoke.
Thanks, Matthew. Yeah, and I think sort of absolutely building on comments already made, but yeah, a really exciting opportunity that I see is the potential sort of increased value placed on cataract data at the national level, given the WHA target and sort of the reporting requirements around that. And so I guess a key opportunity is that facilities do tend to collect a lot of service-based data for cataract. And it's really sort of, that can be used for us to know whether or not we're moving in the right direction. And I think Stuart sort of pointed to this. Sort of a key challenge is the quality of that data. And I think sort of establishing the processes to strengthen the health information system and then including sort of the compilation of data collected at that facility level, and it makes its way up through administrative levels up to the national level. And yeah, as you mentioned, Matthew, we're currently working with the Fred Hollows Foundation on a really exciting project with partners in China and Nepal, and I think some of them are on the call today, which is great. And we're trying to develop methods where we might be able to estimate ECSC drawing on routinely collected data. And I guess through this process, it's been really heartening to see stakeholders recognize that value in the data that's being collected at the facility level. And we're starting to strengthen, the data and supporting processes. So I'm sort of really hopeful that we're sort of pulling together a methodology that might really help strengthen that health information system, but then give us the ability to track ECSC in between population-based surveys.
Thank you, Jackie. We've just got a few moments left. I just want to quickly come back to Stuart and possibly Andrew to ask a bit about some of the challenges, but also the opportunities in relation to the eye health workforce. And then if we've got time, we've got a couple of questions in the chat I'd like to try and...
Thanks, Matthew. I'll be very quick. And I think I'll be very quick because I think Monica gave a very good overview of workforce strengthening at a country level. So just to emphasize a few of Monica's points, I think, of course, it is one of the biggest bottlenecks to scaling up access to cataract surgery services. But I think we need to think about it in a way that it doesn't just mean increasing the number of surgeons. That's, of course, needed, no doubt. That is, of course, needed, but it does, of course, take time as well. Sort of more lower hanging fruits are, of course, addressing some of the inefficiencies in the existing workforce, which were alluded to before. And I don't say inefficiencies in a negative way. I say it in a way that many surgeons are tied up with non-surgical tasks that could potentially be alleviated at lower levels of care. And this is only possible going back to Monica's point. We need to really fundamentally build a strong eye care within primary healthcare to be able to for this to happen and to improve these efficiencies. So I'll leave it there, and Andrew may have something to add.
Yeah, very, very briefly, I'll just build on that, although I agree we need more surgeons, I think first we need more surgeries, because what we see in the data is usually 20% of the surgical workforce is doing often close to 80% of the surgical throughput. So there's a few, if you like, outlier high volume surgeons, and it's not necessarily because others don't want to do the work, but the ecosystem and all the things that have been described eloquently by Monica and others isn't in place. So actually, until we solve those problems, the capability to make becoming an ophthalmologist or part of the ophthalmic workforce an attractive profession is also limited, because until it's optimized, until there's the capability to work in partnership with other people, you don't have a community of other practitioners, and so it becomes quite a lonely role, particularly if you're trying to work in the underserved areas. So I think we've got to address that as a critical near-term thing, optimizing the services to do more surgery, with a view longer term, bringing in more surgeons into the profession.
Thank you, Andrew. We're at the top of the hour, so it's the end of our time together. I just wanted to say thank you very much to all of you online for taking the time to join us. Thank you very much to the panel for the talks and the discussion we've just had. Lots of food for thought. Just want to mention that we will be sending out to all those who registered for this webinar links to the recording, to the papers, and we will endeavour to respond to the questions in the chat and the Q&A box as a circular, the frequently asked questions. So hopefully, thank you very much for proposing those questions, and we will get back with a sort of circular response for that. Just to say, we're going to probably have some more such webinars